I'd like to go against the current this afternoon by talking about the one thing that conjoins us all, and that's health, and more particularly, ill health. The sad fact is that at some point in all of our lives, we are going to experience ill health. But how we experience that is going to change radically, depending on who we are and where we are. And that's why Dr. Martin Luther King said, of all the forms of inequality, it's injustice in healthcare that is the most shocking and inhumane. So let's talk about this for a minute. The lights are bright, but I think I can see the hands here. I'm just going to put up a few illnesses. Now, if you know someone who has suffered from one of these illnesses, if you're comfortable doing so, just raise your hand. And I mean, you know them. You've looked in their eyes. You could tell me their story. Does anybody here know anyone who suffered from guinea worm disease? There's not a lot of hands up. How about polio? There's a few hands up now, yeah. This was a condition that currently takes its effect in West Africa. It used to take its effect in New Brunswick with some severity. How about tuberculosis? A few more hands. If you come from a First Nations community in Canada or live in Canada's Arctic, you probably know someone who suffered from tuberculosis. And what about HIV? There's more hands here. Okay, one more. Cancer. That's every hand up, including my own, right? Everybody's got a story about cancer. Everybody knows someone who has cancer. And this is the problem. We have burdened the crab as being the mascot for cancer. And it doesn't make much sense, because when Hippocrates, back in his day, when he saw cancer, not a whole lot, but when he did see it, he saw this tumor coming through skin, protruding, with the cells extending. He said it looked like a crab. I think we need a new mascot. I think we need the mascot to be the elephant. Not because of the trunk or the cute ears or anything else, but because this elephant is in the room. Every single day around the world, we lose 20,821 people due to cancers. That's on a global scale. Now, if we map this out, as you can see here, here's most of the countries in the world that have a cancer registry. This is breast cancer, new cases per 100,000, and we've done a gross domestic product at the bottom to spread it out. You can see the color coding in the map in the top right. There's the United States up at the top, very high rates of new cases of breast cancer. There's Ethiopia and some other countries to give you a comparison. If you look at this too quickly, you will see that there is an economic association between the new cases of breast cancer and the wealth of a nation. A lot in the United States, a lot in Canada, not so much in Ethiopia. This is a problem. This is a problem on a global scale, even though this kind of data does inspire us to invest in all sorts of great research, right? We're dealing with cancer in ways now that we were not doing so 10 years ago. The survival rates are getting better. The experience is getting better. When you are in Canada and you get a cancer diagnosis, rest assured the cavalry is coming for you, right? We can do that. But unfortunately, it's led to some other erroneous claims about how we look at cancer on a global scale. This sort of lucid prophecy that took place in 1991, where the writing to say the concern over an agent that causes a 1 in a million change in the odds of prostate cancer is obviously going to be much higher in a country where people survive to get prostate cancer. Now, who said that? That was Larry Summers, who was the former chief economist of the World Bank, former president of Harvard, and former secretary of the Treasury. When you look at this case here, Nexivar, this is an oncology drug for people who've got liver and kidney cancers. The president of CEO, the CEO of Bayer, Marjan Decker, said, "We did not develop this drug for India. We developed it for Western patients who can afford it." Now that's a problem, because these two short-sighted views are just looking at this data. So let's go against the current. Let's change that data. Let's not look at new cases of cancer per 100,000. Let's look at the mortality rate. And when you look at the mortality rate, it changes dramatically. The Philippines has the highest mortality rate of breast cancer anywhere in the world. Ethiopia is now above that of the United States. The same exercise holds true if we look at prostate cancer, because now we are screening for prostate cancer in the global north. Ethiopia, Uganda, Zambia, not so much. But when you move the numbers around again, it is an overwhelmingly high amount of mortality due to cancer in Uganda. You see that economic association has disappeared when you look at it in this way. But yet our international policy has not reflected this. Look at it even in this way. This is cervical cancer. That's Haiti floating to the top. There is no biological reason why there should be so many more new cases of cervical cancer in Haiti than there is in Canada and the United States. It's only a 4-hour flight away. And when you look at the mortality rate, Now, there is a very clear indicator that most of the overwhelming burden is on the African continent and in low-resource countries. So what are we doing about it? What do we give? What we give to Africa, if you look at the numbers of official foreign assistance from the United States, official development assistance, the U.S. gave $7.7 billion to HIV in 2009. Tuberculosis received $4.4 billion in 2012. Polio received $1.1 billion in 2010. Guinea worm disease received $32 million in 2011. But how much came from official development assistance to cancer in Africa? Under $1 million in 2010, and that was a record year. Closer to home, if you go onto the Government of Canada's development project browser, you can type in key letters and terms like HIV. It's a pretty cool tool because you can see we've got 218 projects around the world with a total of $2.8 billion is what we're giving to HIV/AIDS around the world. Do the same exercise with the words cancer and Africa. What do we give? Nothing. Absolutely nothing. The total budget is zero. And that's been zero for a long time in this country. Why are we comfortable to do that? Is that because we've entrusted chief economists of World Banks and CEOs of pharmaceutical companies? No, it's so tacit. Just recently in The Lancet, an outstanding medical journal, they did a special issue about global rates of cancer, acknowledging that it exists, acknowledging that it is a problem. As much as HIV/AIDS identified and defined global health in the 20th century, it will be cancer that does it in the 21st. And again, here, when we are confronted with a cancer challenge, there's the moral emphasis to find ways to organize, to take care of each other. But listen to how this gets read from the editorial board. There's no point in giving free cancer drugs to Africa. Across Africa, treatment abandonment occurs not only because of financial constraints, but because of the predominance of alternative healers and beliefs. There is a strong belief in alternative medicine and traditional healers here in this country and in the United States, and we still make the effort to try to take care of each other. This is not a legitimate excuse from a medical journal of that standard. Continuing on, 2 years earlier, another article. The returns on health investment might be very low with dysfunctional structures of healthcare, corruption and dysfunction. You need not go to the African continent to find corruption and dysfunction. Open up any newspaper in this country on any day and you will find it. And we still make the connection to try to take care of each other. The latest one. This one takes the cake. Many factors outside of healthcare, such as foreign languages, politics, geography, the color of the sky, whatever you want. Right? This is completely unacceptable. We would never tolerate this sort of research to say we're going to not deal with cancer in Canada because of the size of the country. Right? I'm not saying that we have the perfect solutions, but if this is the moral platform that we get going, we're not doing a good job on it. Now, why do I bring this up? It's not just because I moved around some graphics and some data, it's because I have seen it. In 2010, I had the great opportunity to work on the research project between Uganda, Rwanda, and Burundi with a friend of mine, William, who's from Entebbe, Uganda. And we were heading down to Burundi through Rwanda. He brought his daughter along. And on this trip, she became so ill. She had fever. She had pain. She was vomiting. And of course, as we were going from clinic to clinic, they said, she's got malaria. Oh, no, it's probably did she eat something, right? It wasn't until we were in Burundi when it really got severe. And we opened up the travel guide, and we looked through it. As the travel guide reads, if you are in Burundi and you need medical care, leave Burundi, is what it read. So we left Burundi, right, because we were foreigners and had the means to do so. We went to Rwanda. And in Rwanda, they did some tests. They did some more tests. They did some more tests, and then they did a scan. They found that she had stage 4 ovarian cancer. That had spread. And 6 weeks later, she was gone. But not before William nearly bankrupted himself trying to get second-rate knockoff oncology drugs from China and India. And this is the state of oncology wards across Africa. Why is that? Is that just due to logistics? We're not all experts in that, but I think we can have a discussion at a higher level. Do we even understand what health is? If I was to ask you to define health, could you do it? It's difficult. Here's 5 definitions for you. Now, 1 in 3 come out of biology textbooks, right? You can see the language there, but take a special note of 2 and 4. The freedom from disease or the freedom from illness or injury. Now, I'm not an expert in dictionary writing, but I know one thing for sure, that when you look up something in a dictionary, it does not define itself for which it is not. When you look up what is an apple, it doesn't say not an orange. So why in the world are we this comfortable with the definition of health in this way? The problem is with, like as I said, with 1 and 3, those come from biology textbooks. 2 and 4 come from medical textbooks. Medical textbooks used at this university and at others. And if this is the founding block to understand what health is, we're in a bit of a bad way, especially when other understandings like number 5 exist. I want to just sort of sidetrack for a minute. What would you say is the most important moment in history? This has nothing to do with cancer, but it's got everything to do with cancer. I'm not talking about declarations of war or presidents' birthdays. I mean a real quiet moment when there was inception of an idea that just spread. I mean, throughout history, I would like to say that it was a sunny Sunday afternoon in Paris in 1893 when some engineers got together and said, we are going to have a race of the horseless carriage. They brought together different types of horseless carriages. There was the one that ran on water, there was the one that ran on electricity, there was the one that ran on petroleum, and there was the one that ran on both petroleum and electricity, a hybrid, in 1893. The petroleum one won because the values of that race, of that competition, was for power and speed, and thereby it gave the internal combustion engine the gold medal, something that still powers most of the world over 100 years later. Even though it's leaky, mechanical, it breaks down all the time, you had to refuel the thing frequently. This was given the top marks. And as a result, Le Petit Journal, a little publication in Paris, started the conversation that the internal combustion engine was the best way forward. And it radically changed how we organized ourselves in the 20th century. We redesigned our cities around the internal combustion engine. Now, granted, there are some beautiful creations like the 1956 Chevy Bel Air V8 with automatic transmission, convertible, and chrome rims. Yes, gorgeous thing, right? My buddy Julio's car, it's a gem. But we also see some of the most catastrophic environmental conditions that have come trying to feed these engines. And even more worrisome is that we had this kind of cool planet in 1884, but in our quest to feed these engines, we've made it very hot and uncomfortable. All because we started with one idea in 1893 that nobody challenged. Same goes true with global health. There's a history here of competing ideas, and some tend to dominate more than others. This is the League of Nations Malaria Brigade, a group of white men who went to the colonies for one specific purpose, to try to prevent the spread of disease. In their mind, they visioned that the 20s and the 30s would be this glorious time where we'd be cruising around the world in these comfortable airships, but with it would be the risk of spreading disease and illness. So their solution was, we will address disease and illness. We will do vaccination campaigns, right? We will create medicine to give out throughout the global south, and by all means, vaccines are wonderful things, right? Medicine's technology in this way have helped most of us live a longer, happier life. But at the same time, there was debate. There was debate, especially around 1934, about moving just from vaccines to trying to prevent illness in the first place, moving into hygiene, social medicine. We had two competing ideas coming along, and then after World War II, in 1946, the United Nations said, we need a guiding force. We need a moral authority on how to take care of ourselves in the global world. So we'll need the World Health Organization as that body to deal with our health needs. After World War II, penicillin was the real hero, right? This was the first war in modern warfare where most people actually died from combat itself or from bombing, not from infection, because penicillin made such a big claim. And yes, it's had its benefits. But that narrative, that idea took off to such a degree that the World Health Organization put most of its efforts into eradicating diseases. Smallpox, which we did. Malaria, which we didn't. And it doesn't really account for the panoply of other diseases around the world, which is why in 1978, in Alma-Ata, Kazakhstan, there was a meeting, an assembly of all nations to come together to talk about how to make the world healthier by the year 2000 through universal health care. That was the plan. Unfortunately, the 1980s came along, recessions came along, the Soviet Union fell apart, and these ideas were dismissed as commie pinko fluff, right? The idea of universal health care by 2000 was quickly scuttled. And in the 1990s, with the rise of the HIV/AIDS epidemic in Africa, which has transformed the demography of that continent in numerous ways, Mr. Gates and others come along and say, we're going to get a lot of money, put it into a few drugs, and it's going to get better. Now, no doubt, because of those drugs, many people have benefited. Many people have led better lives as a result of it. But if we are focused on this idea as the only way to take care of other people, we're doomed when it comes to cancer. And we don't have to be. Because also in The Lancet was this article here that acknowledged that Africa accounts for only 0.3% of the worldwide medical expenditure for cancer. And the article goes on to say that the way to deal with this is by building resiliency, strength, comprehensive care, building human resources, delivering equitable, rights-based care. Looking back to Rwanda as an example of this, and this is coming from Dr. Paul Farmer from Partners in Health. He's worked in Rwanda for some time. And what Dr. Farmer is saying here, he's not proposing a cure for cancer. He's saying that we just need to have the right approach, that if we're going to deal with cancer abroad, we deal with it the same moral platform that we would deal with each other. We start taking care of each other. We start by getting the colonial language out of medical journals and start to bring it in ways that we would expect it for ourselves. Designed for everyone as the Ontario Cancer Plan. This is the kind of language we expect. Because when we know, if you receive the unfortunate news that cancer is going to be part of your life, treatment begins. The cavalry's coming, and it's alarmingly expensive. The nurses, the physicians, the specialists, the pharmacists, the nutritionists, the social workers are all going to be there to try to make sure that you get to where you need to be. And this costly system is only possible when we support it as a society. So why can't it go beyond borders? Why can't it scale up to other nations? Well, we need an example of that. And here we turn to Cuba, where its Department of Radiation and Oncology does just that. The place needs a coat of paint, I'm not going to lie. But at the same time, it's the one example of a nation that has no problem giving oncology medicine to children from other countries, especially children from the left side of the street, so that they can make it through. And I wonder if now we're ready for our next great moment in global health. The inception of that idea that we start taking care of each other. We start getting the colonial rhetoric out of these editorials, and we start looking at health for the sake of health. I hope we can do that. I hope we can disseminate that plan. Otherwise, we just have to put up with this guy somehow. Thank you.